Today we are going to be discussing preoperative fasting and its different implementations. Fasting for a period before undergoing surgical intervention and being administered anaesthesia is an absolute vital part of the preoperative checklist. Fasting allows the gastric contents of the stomach to mostly be eliminated and to have time to neutralise to reduce the risk of aspirating during surgery. Onset of anaesthesia temporarily suppresses the body's swallow reflex, which can result in gastric contents emptying into the lungs and can cause many complications. The acidity of the gastric contents, such as food, bile, and gastric acid, can cause inflammation of the alveoli in the lungs and can interfere with gas exchange, which may lead to respiratory arrest and potential death. It has been commonplace among many surgeons to extend fasting from midnight prior to surgery to avoid the risk of surgical aspiration, despite new guidelines. According to the New South Wales Agency for Clinical Innovation, or the ACI, general patients only need to refrain from solids for 6 hours and refrain from clear fluids for 2 hours prior to general anaesthesia, regional anaesthesia, and sedation. Variances are so common among each hospital and each surgeon's preference, despite the ACI guidelines, because they are strictly guidelines and not New South Wales health policy. Therefore, there is more lenience for hospitals and surgeons to preference fasting from midnight as opposed to 6 hours before theatre. In New South Wales, the Australian and New Zealand College of Anaesthetists, or the ANZACA, has recommended fasting guidelines for patients across the lifespan who are not at risk of respiratory aspiration during anaesthesia. Adults are recommended to fast from solids for 6 hours and clear fluids for 2 hours, as stated earlier. Children aged 6 months and older are to fast from solids, breast milk, and formula for 6 hours and clear fluids for 2 hours. And infants younger than 6 months are to fast from formula for 4 hours, breast milk for 3 hours, and clear fluids for 2 hours prior to anaesthesia. These clear fluids include water, pulp-free fruit juice, clear cordial, black tea, and black coffee. These clear fluids strictly exclude drinks containing red, blue, and purple food colouring, as well as jelly. Patients can also take their prescribed medication less than 2 hours prior to anaesthesia with a sip of water, unless specified otherwise. The ANZACA states that patients at risk of aspiration of gastric contents during procedure, or patients that are suspected to have delayed gastric emptying, can be prescribed proton pump inhibitors and H2 antagonists to increase the pH of the gastric contents and essentially lower the amount of gastric contents pre-anaesthesia. A study conducted by Abdullah Al-Makbali explored the median length of fasting times among many different countries by evaluating various studies. The study concluded that fasting times for solids ranged from 3 hours to 19 hours, and fasting from clear fluids ranged from 3.1 hours to 12 hours. It is made evident by this study how grossly inconsistent fasting periods for both solids and clear fluids are among many different countries and not just in Australia. The American Society of Anesthesiology suggests that as a part of the preoperative checklist, nurses and surgeons need to liaise with patients on any relevant health history. They need to be aware of conditions such as gastroesophageal reflux disorder, or GORD, dysphagia, diabetes, other gastrointestinal motility disorders such as vomiting, and respiratory disorders that may invoke difficult airway management that may predispose the patient to pulmonary aspiration during surgery. It is also important to note whether a patient is a smoker, has recently consumed large amounts of alcohol, or has been taking any opioids, as this may incur delayed gastric emptying and may determine whether a patient's fasting needs to be modified. It is important for nurses to engage with patients and inform them of the hospital or surgeon's fasting requirements and the reasoning behind fasting so that compliance can be maintained. Due to inconsistencies with surgeon preferences for fasting lengths, It is important for nurses to monitor patients' fluid and food intake prior to surgery, and to follow the surgeon's requests so that surgery delay does not occur and the patient's fasting period does not need to be extended or rescheduled. If compliance is not maintained, the surgeon will weigh the risks and they will determine whether theatre will continue. Nurses need to be knowledgeable and keep up to date with current guidelines on preoperative fasting, as some surgeons are pushing to decrease fasting periods and oblige by the guidelines, while others follow traditional guidelines. Nurses need to be compliant with both nil by mouth from midnight or nil by mouth 6 hours prior to surgery. When extended fasting occurs, patients are at risk of dehydration, insulin resistance, electrolyte imbalance, nausea, vomiting, irritability, confusion, anxiety, and hypertension, which may lead to patient non-compliance and dissatisfaction. When patients fast for extended periods, often their recovery is longer than those who fast within the guidelines. This extended recovery results in a lower turnover of patients due to the delayed discharge. Studies have shown that the incidence of post-operative nausea and vomiting increases with extended fasting, as well as a change in tolerance to pain. A study published in the British Medical Journal states that of the patients who consumed water up to 2 hours preoperatively, only 18% experienced post-operative nausea and vomiting, whereas those who fasted from midnight had an incidence of 35%. It is in the best interest of the patients and the medical facilities in which these surgeries take place to have lowered post-operative complications to ensure discharges are not delayed. Due to the consistent past history of extended fasting and the misconception that extended fasting equals greater gastric emptying, despite the evidence to prove otherwise, we are still seeing the outdated nil by mouth from midnight prior to anaesthesia. Conclusively, surgeons and nurses are the responsible parties who dictate patient fasting times. In order to finally see a greater move from traditional fasting from midnight to a more modern fasting 6 hours for solids and 2 hours for clear fluids, nurses and surgeons must strive for greater professional development and knowledge. As the updated guidelines are followed to a greater scale, patients and hospitals will benefit more due to the reduction in post-operative complications and an increase in overall patient satisfaction.